A very good evening to you, ladies and gentlemen. Thank you very much for joining with us for this online lecture, which is organized by Dentistry, which is the academic arm of the Government Dental Surgeons Association. As you are well aware, we started off this lecture series based on dental implants. And today we are going to start the lecture, which is the fourth lecture of this lecture series on implants, which is under the topic of the prosthetic ballet of dental implants. So today our lecturer is well known, and I think the dental undergraduates are very fond of this lecturer because the prosthetic dentistry is a very hard and difficult subject, but because of him, he had been able to like simplify the subject and has been able to disseminate knowledge among the undergraduates recently. And lecturer is none other than Dr. Aruna Wimalarathne. He's a lecturer in prosthetic Department of Prosthetic Dentistry in the Faculty of Dental Sciences, University of Wimalarathne. Thank you very much, Dr. Aruna, for accepting our invitation. Currently, he is undergoing foreign training in Australia. And at the moment, I think the time in Australia is around 1:30 a.m. And he had put in a lot of effort to join with us for this lecture and share his knowledge and experience. So without further ado, I'd like to invite Dr. Aruna Wimalarathne to continue with today's lecture. It's over to you, sir.
Thank you, Kemia. I'm really happy and glad to do this lecture. And at the same time, I would like to thank you for you invite me to do this lecture and share my experiences. I hope everybody will enjoy this lecture and you can get something out of my knowledge related to the dental implant. Okay, Okay. Today, we are planning to discuss something about crafting smile, the prosthetic ballet of dental implants. I'm really happy to accept this topic. Thank you so much, Kemia, for suggesting such a wonderful topic. Actually, here today, I'm going to talk something about dental implants, how you can use that implant to make creating a better smile for your patient. That is the most important things, not aesthetic as well as the function. Okay, this is always I'm talking about the implant, but implant is not an implant until you implant it. That is my quote because I want to say that everybody talking about the implant, but something lack behind the rationale of the implant, because even you have the piece of metal outside, you call it as implant, but once you definitely it to be an implant, it should be implanted into the patient's jawbone and it's going to be successfully osseointegrated. At the same time, it should be functionally and aesthetically well. Then only we can say it as an implant. Okay, to complete my lecture today, I'm planning to discuss something about the type of prosthesis we can use it by using implant and how to manage the different varieties of missing teeth, single implants and multiple implants. At the same time, we can talk about the provisional restorations and multiple implants and edentulous arch. At the same time, at the end of my presentation, at the latter part of my presentation, I would like to share a couple of cases which I did as a multi-disciplinary way to rehabilitate the full mouth rehabilitation. Okay, once you talk about the topic, today we are blend our topic with the ballet dancer, right? Once you see this dancer, you can see something and very perfect manner, especially the balance of this dance and the costume. Then once you see this dancer, you can see the professionalism of this. I mean, that dancer is a very professional, right? Believe me, none of these dances can't be a dancer within a one day, right? Because behind the screen, there are a lot of dedications, commitment, knowledge, sacrifices, as well as lot of commitments are there. I wanted to tell you, if you want to do an implant like Implant also same, because even you place the implant, if you think about it, the outcome of that implant, it should be aesthetically as well as functionally, it should be perfect. If you think about this one, you can't do in a 1 day or 2 day. For that, you have to have a lot of dedications, commitment. For that, you have to have a proper basic knowledge as well as a skill, and you have to apply that knowledge and a skill in an appropriate manner for the particular case. Okay, believe me, single implant placement is the most difficult thing compared to the other cases. Okay, at the end of this presentation, you will understand what are the things actually you have to looking for once you plan for your single implant placement. Right. This is the fundamental rule to be a success, to gain a successful outcome in a single dental implant. It should be prosthetically driven. That is the quote, and that is the thing you have to think about. It should be prosthetically driven. Implant placement is the secret of aesthetically and functionally pleasing dental implant processes. I'm not going to talk about the implant surgery, implant assessment, and all the other things, because I know previously there are 3 lectures already done, and all the expertise talk about how to place the implant and how to assess the patients, right? But sometimes they miss this thing, right? Even you, once you place the implant, you have to think about the futuristic manner, because one day, even you lay down the foundation of a house, if you think about, but before you lay down the foundations, you have to think about all the components. How can you build upon it? That is the basic idea of prosthetically driven concept. Okay, based on the different ways you can categorize the implant in a different way. If you have single missing teeth, you can place the implant crowns and then the bridge, then over dentures for the edentulous cases. Then depend on the processes, how you can apply and how can you load the implant. There are 3 types. Either you can go for immediate replacement or early replacement or delayed replacements. I'm not going to talk about this. I think already these things are covered. Okay, then later you have to think about how to retain or how to support your prosthesis on top of the implant. There are 3 different ways you can use. Either you can use a cement retain prosthesis, or you can use a screw to retain your prosthesis, or you can use different types and varieties of attachments. We will talk everything during my presentation. Okay, by using all the different varieties of replacement timing as well as the components or the attachments, you can go for a single retained crowns for management of a single tooth, and multiple teeth missing cases you can deal with the dental bridges. At the same time, if it is a edentulous case, you can think about the implant retain or supported over dentures. And once you talk about the full mouth rehabilitations, either different varieties of combinations or same types of type of implant methods you can use for full mouth rehabilitation. Okay, always you have to think about, once you replace the missing tooth, always try to mimic the function and aesthetic of the natural tooth. That is the things always you have to keep in your mind once you plan your cases, right? Once you think about the missing teeth replacement, especially the simple cases that you think, but that is the most difficult cases, believe me, because single tooth replacement, always there are things you have to plan at the beginning. Number one is a pre-prosthetic assessment. Then you have to arrive to the diagnosis and treatment planning. Then you have to come to the surgical placement of the implant. During the prosthetic assessment, pre-prosthetic assessment, you have to think about the soft tissues and hard tissues, edentulous spaces and adjacent teeth and opposing teeth. Then you have to, during the planning, there are a lot of things you have to think. One by one, we will go through, right? Then soft tissue and hard tissue evaluation is very important and very critical, because gingival color, it's reflect the aesthetic outcome at the end of your processes. it always help you to select the crown color. Okay, here the color means hue, chrome, value, or everything in together gives a lot of idea to the mucosa, because dealing with the soft, dealing with the white and pink is very critical thing once you think about the aesthetic of the processes, because always contrast in between the pink and gingiva, sorry, pink and the white. Here we are talking about the crown and the gingiva is very important. At the same time, gingival biotype is very important, because here gingival biotypes gives a lot of idea about how to select your implant material even. For example, if you have a thin biotypes and you are using titanium implants, sometimes you can reflect and you can see that metallic appearance through the gum or the mucosa. It is very ugly, if especially if patient having high lip line or high smile line. At the same times, gingiva reflect the periodontal status around the implant and the crown. It's very important. You can easily identify the whether the gingiva is healthy or it's inflamed or diseased or there are any active diseases going on. It's very important. This is bread and butter. If you don't have healthy periodontium, don't place the implant until you resolve that problem. That is very basic. Sometimes you place the implant and at the same time you can think, okay, we have at least 2-3 months. During that time I'm going to do the periodontal disease management. Don't do that. First you have to manage the periodontal diseases, then only you have to think about the implant placement. At the same time you have to think about, even you have a very good healthy gingiva, the soft tissue contour is utmost important, because it gives the importance of the gingival papilla contour, and it sometimes it shows you the buccal plate analysis also important at the same time. Sometimes you can see the gingiva as well as the papilla contour, but underneath there is a no bone. Therefore you have to think about the investigations beforehand once you place the implant. Okay, in here you can easily you can see the horizontal defects, right? For example, in second picture you can see how much the ridge is constricted, or normally we call it as a necking or constrictions of the ridge. Okay, at the same time you can think about how, if you want to place the implant somewhere around here, you have to place the implant. Then maybe your implant position or angulations can be changed. Then you have to think what are the remedies or what are the management you have to think before you place the implant, especially if you have a horizontal deficiencies in your implant side. At the same time, if you have a vertical deficiencies, as I said, sometimes you can see papilla, but it very straight, not curved or elliptical shape in your mucosa or the ridge. Then once you place the implant, you are end up with this kind of a black triangle. It's very ugly. You can't correct once you place the crown. Okay, for here you have to think different ways to overcome those problems, right? Especially there are two different techniques you can, and another technique actually management protocols to do such situations. Once you observe if there is such a huge deficiency in horizontal manner, the one option is you have to place purposely, you have to place the implant palatally, right? Because now you selecting the pathway where the bone is available. Always you have to think about the available bone quality and the quantity. Here you are thinking about the available bone in the palatal side, then you have to place the implant in palatally. Then you are in trouble once you place the crown. That's why I want to tell you, then there is no any other way. Then you have to think about the ridge lab restoration. Okay, that's how you have to manage That's how you have to craft your smile. Look at the cross section of ridge lap restoration. Huge over contouring, and at the same time, it can be hygienic difficulties as well as it compromise your aesthetic, and over contour margins are very, very badly affected, especially if the patient is having high smile line. Then the other option is, beforehand you place the implant, you can think about the bone augmentation of this one. Here, actually, you have a horizontal bone deficiency. Then you have to raise the flap, and there are a lot of techniques to improve the bone availability around your implant site. One way is you have to raise the flap, then you have to think about the block bone graft, and you have to put the autogenous or artificial bone, and then you have to do the bone graft one way. Or you can split the bone and you can do the bone expansion, or you can use osteodensification bursts and you can increase the bone density as well as you can increase the diameter and the contour of the bone same time. With that, you can change and you can enhance the aesthetically pleasing position of implant placement because you are changing the contour of the bone. We call it as a bone augmentation. Okay, this is one of the case. Here you can see there's a huge necking and the bone is ultra thin. Then what we can do is open up the flap and you can think about the block bone graft plus normal bone grafting together. Then after at least 6 to 8 months 6 to 8 months later, you can reopen it. Then you can see the difference between the first and fourth photographs. You can see how much bone you can augmented. Then easily you can place the implant in ideal position and look at the outcome. Otherwise, if you place the implant as it is, you have to put the crown with the rich lap crowns. Then you can see very bad contour and your smile and outcome is definitely going to be affected. And then you as well as the patient's going to be unhappy at the end of the treatment. You are wasting your time, money, and ultimately you don't have job satisfaction, as well as patient also has that kind of a bad image on you and your treatment and everything. Then we have to be very careful before you tackle these cases. You have to think about what actually you have to do at the beginning. Okay, then the other important thing is edentulous space. Okay, that's why I'm think told you this is very important to know about the surroundings of your implant site before you place the implant. That is the most important. That's why I told you prosthetically driven management is the secret. Okay, then intra-arch distance minimum, at least you have to have a 2 mm anterior and 4 mm posterior. Here it doesn't mean if you have a 2 mm you can place an implant. Here we are talking about the clearance of once you have a occlusion, once you have a centric occlusion, once the upper and lower teeth are contact each other, at least you have to have a 2 mm. It means if you have a traumatic overbite, or if you don't have or if there is no any posterior teeth and there is a very limited occlusal clearance, but you have a huge ridge, once you open the mouth and once you examine the implant site, you can think, oh my goodness me, we have a lot of bone, then we can go and place the implant. You are so happy. And once you place the implant, and after 3 months, once you remove the healing cap, and once you try to get the impression on, you realize even you can't place the impression trans or the impression cope in there because it's touched your lower teeth, and you can't, then only you realize your implant placement is wrong. There is no enough room to contour and fabricate your crown. That's why at least this much of a distance is very important. At the same time, buccal cantilever, right? Otherwise, what happen? Once you place the implant, in line diagram, you can see your implant position is somewhere. Then white dotted line, you can see that is the usual way you have to place the implant. But if you don't have this much of a tiny gap even in between the lower teeth and the upper ridge, you have to purposely, you have to over contour or the buccal cantilever your crown to get the access for the contact of lowers. Then automatically it's given the over contoured in buccally as well as it's ugly. At the same times, sometimes you will be unable to provide a proper occlusion, right? Then what happened? There is an unnecessary load or the unnecessary premature contact or kind of a jiggling forces, the chronic minute forces applying over and over again on your implant crown, and ultimately you end up with trouble, either implant loosening or screw loosening or implant failure, or a lot of things can be happened. Otherwise, your implant will retain as it is, but aesthetically it's going to be very poor. Right. Then the most important thing is you have to analyze the mesiodistal distance against the contralateral. Remember, against contralateral. There are three things can be happen. Once you remove the teeth, or once you lose the teeth, either patient can bear the removable partial danger as a space maintainer or as a management. Then you are lucky because then you can maintain the space as it is, very similar to the contralateral. Okay, then no need to do anything. And as a first photographs, if you can see, there is a increased mesiodistal width as well as the lateral is rotated also. Then you are in trouble because you have to think about two different things. One thing is you have to think about the crown length and crown width at the same times the contact point because it's a rotated one. Then you have to think two different things at the same time. If you have as a third picture, if sometimes three things can happen. Either you can maintain the space as it is, or it can be lost your space, or it can be increased because of the migration of the teeth. It can be increase the distance. Then I think if you can easily, you can use the chat box. Then you can share our knowledge and your experiences and your thoughts. It's be very good, right? Then you just matter of typing. I'm not going to tell your names, but I can get some ideas from your discussion as well. It's going to be very fruitful and informative for the others. Okay, let me know. Somebody can type it if there is a spatial closure, what you can do actually. And at the same time, if there is the gap is increased, what will you do in your cases? Anybody? Okay, then two things you can do. Either if there is any space analysis, you have to do number one. Then if there is any spacing, you can think about the orthodontic combination treatment and you can increase the space according to the contralateral, then you can do. Or if there is an increased spaced, once again, you can think about the orthodontic treatment, or you can recontour in the either side abutment teeth, adjacent teeth, and then you have to manage the space. Or maybe patient had median diastema, then you have to prior permission and consent and education and everything you have to do, and you can discuss with the patients whether the patient is ready to do the fabrication with the median diastema or spacing. Those are the things you have to discuss with the patients. Otherwise, at the end, you are in trouble. Okay. Then you have to think about the adjacent teeth. Adjacent teeth evaluation is very important for several reasons. One thing is the prognosis. Sometimes there are some failures in adjacent teeth, or there are maybe pathological conditions. It can be easily transmit to your implant site, and you end up with trouble, or it can be flare up at the with the time. At the same time, soft tissue contour level of the either side teeth also important. Then only you have to think about the gingival contour and papilla, zenith, black triangle management, gingival recession. Everything is matter to craft your smile, especially in the aesthetic zone. And the position of the adjacent teeth is very important. As previously I told you, if the tooth is rotated, then you are in big trouble once you make the contact point or the contact area with the adjacent teeth. And if there is any tilted or out of curve, or I mean the crowding or tooth in a different awkward manner, or the tooth is extruded or the intruded positions, then very difficult to get the contact point to the proximal side. Then you have to be very, very cautious about that because of a two reason. One thing, definitely your aesthetic going to be problematic. The other thing is it can be end up with the food packing and cause for functional defects, as well as it can be end up with the periodontal diseases and ultimately end up with the peri-implantitis. I'm not saying each and every cases end up with peri-implantitis, but aesthetically and functionally it can be affected. And wear facets give in lot of information. For example, if you can identify there is any wear facet on enamel or the even for the posterior teeth, then you have to think about the patient might be having some parafunctional habits, and it can be end up with the unnecessary forces or unnecessary overloading can be happen in your implant processes. Then you have to have a precautions and management strategies beforehand. The next thing is the restoration and material of the adjacent teeth. Here I'm talking about sometimes even the posterior side, you have the adjacent teeth sometimes having an older crown. It may be affect for your color combination. If the tooth is restored with a metal crown, then you have to think about. Or if your tooth is restored with the tooth color material, either zirconia or PFM crown, then you have to think about the marginal defects and everything. You have to think whether this tooth also you have to restore together with your new implant restoration. Or sometimes that tooth can be endodontically treated and heavily restored, sometimes over contoured, or there are some overhangings, then you have to correct them. If it is a sound tooth, it's a different things. Then you have to limit within the enamel to the enameloplasty, and you have to recontour to improve the proximal contacts with the implant restoration. Or if it is a restoration is there, then no no need to worry too much because it's not a sound tooth. Of course, then you can do the trimming and chopping and whatever the things you can do according to the space regeneration and space creation. And ultimately you can think about that tooth also you have to do some restoration. Likewise, the restoration and the material of the adjacent teeth is very important once you make the smile. Okay, here some of the photographs. Here you the radiological images you can see. Even the first one, if you place the implant without knowing these things, easily it can be migrate towards your implant site, and definitely it's going to be affect your osseointegration. The second one, there is a little tiny already established chronic case, but once you place the implant, it can be flare up and it can be activated. Or at the same time, the adjacent tooth already gutta percha or the endodontic material is already exposed. Then you have to imagine there is a no acute lesion or radiological abnormalities you can see, but chronological, and then easily you can see once you open the mouth, you can see there is a uh, exposure or the coronal seal is not in that endodontical tooth. Okay, even at that time, once you place the implant, you don't have any issue, but with the time it can be affect. Then you have to think about before you place and plan the implant. Okay, otherwise it can be affect your ultimate result. Even you make a very good smile, it can be end up with a lot of issues after a couple of time. In at the same time, the third photographs you can see endodontically treated and post crown and everything is inside, but you can see bit of a radiolucency in between the two teeth, two roots in intraradicular areas, but you are placing to implant somewhere far away, but with the time it can be end up with huge lesion underneath, and it can be affect your osseointegrated implant one day. Then you have to think about the adjacent teeth pathology before you plan your smile. Okay, at the same time, the adjacent teeth gingival margin is very important, because you have to imaginary lines shows you how it's important. Once you place the implant, even there is no crown there, you have to have that sense how it can be end up with. Are there any enough soft tissue is there, or any other uh, strategical things you have to do beforehand, right? Here you can see in the first photograph, tooth is rotated. Then you have to do some recontouring of the mesial surface of this lateral before replacing the implant. Okay, here gingival level is different because it's flat. Then you have to think about something contour like this. For that, you have to do some bone remodeling, and or sometimes you have to do some soft tissue changes or contouring before you place the implant, or while you are placing the implant, or during placement of your gingival formers. And the rotation also, at least during the implant placement, it's not a big issue, but before you taking an impression, you have to think about. For that, two things you can do. One thing is you have to do, if you are very keen about the digital impression, then you have to do the intraoral and the extraoral, whatever the scanning. Then you can merge with your digital imaging. Then you can use the software and you can make a digital workflow. With that, you can design by using softwares and manipulate everything, and you can think about a very sophisticated manner. Or in your level, if you want to do something at the beginning, you can take a bit of a wax and you can do the wax up. Then you can make the splint in a very, very simple and conventional way. Then you can manage. Otherwise, you are end up with like this. Because once you place the implant, after 3 months only, you realize your placement of soft tissue is very, very badly affected. Then some other how you have to cover it. Sometimes you have to combine with the porcelain, with the pink porcelain. Dealing with the pink porcelain is a nightmare because it's never going to compatible with your natural soft tissue. Then it's easily recognized for anybody. Then it's going to be very, very big trouble, because you can't mimic gingiva with the pink porcelain, right? You can do some camouflage, but you can't get maximum out of it. Then be careful if you have any defect in soft tissues. Okay, occlusion is the opposing teeth. Also, you have to think about. Previously, we talk about the adjacent teeth, then the opposing teeth evaluation is very important. Why I'm saying that occlusion is the main thing once you think about the implant. For example, if your implant is restored and your adjacent teeth, sorry, your opposing teeth is mm, either uh, either having good occlusion and the good periodontal condition, it's not an issue. But imagine there is a guarded prognosis of the opposite teeth, and you are planning to do some implant restoration for the opposite side. What happened once you fabricate one and once you do the restoration on the implant, that opposing tooth going to be overloaded immediately because of very rigid restoration on the other side. Then it can be easily um, flare up and it's going to be end up with trouble. Therefore, you have to think about the prognosis of compromised opposing teeth as well as the type of restoration. For example, sometimes if you have, imagine if you want to cantilever, a couple of teeth is missing in one side, the upper teeth, upper or the lower either side. One side is, one arch is completely dentulous and the other arch is partially dentulous. For example, if it is a Kennedy class 1 or 2, then you are planning to go for 2 implants and you want to cantilever the other tooth, right? But in these situations, if you are wearing a upper denture, no harm to go for a cantilevering because less forces apply on your the extended distally extended bridge. Then there is no such a overload. But imagine if you have upper teeth or the lower teeth, full set of natural teeth, and opposing you are planning to go for a distal cantilever implant supported bridge, then definitely your implant supported bridge going to be compromised because of the opposing arch occlusion. Likewise, you have to think everything um, during your treatment plan. Then once you do and once you completed your analysis and evaluation of the patients, then you have to think about treatment planning and diagnosis. For that, you can do a lot of things, especially if you are a beginner of clinical implant dentistry. My advice is first couple of cases, take and select a very simple case and do these fundamental things. Do wax up and make a small mock up. I mean, you can do some either wax or even with the modeling wax is all right. Then you make a splint, then you can place your implant. Or if you are very keen on your softwares, do software work plan, then you have to go for an implant. Or you are a very expert and you are tackling a very complex case. That's my advice is, once again, don't overconfident and don't overestimate yourself. Okay, I place such an implant and I'm the person who have to tackle all the cases. Don't do that. Do a bit of a wax up and be ready, and you have to imagine and anticipate whatever the consequences at the begin at the end if you didn't do that. Then diagnostic phototypes for the missing teeth would be visualized. Then you can get good idea about the location of the implant and the angulation and everything. You can study it beforehand. Okay, that's what I'm saying. If you want to be a good ballet dancer, you have to do a lot of practice. Otherwise, you can stand like this with a very good stamina and the balance. For that, likewise, if you want to achieve a good outcome aesthetically as well as the functionally, you have to do this kind of a mock-up. It doesn't take that much of a time. It only about your commitment and your attitude changes. If you want to do this kind of a things, these two are my own cases. Still I am practicing it. Then only I can realize how many pontics, how many implants, what is the occlusion, and are there any alterations of crown designs. Everything you can think about once you these mock-ups. Okay, then these the advanced things. Advanced in the sense the next step, once you do the wax up, then you can think about the surgical stent or the template. It can helps to take your imaging as well as the surgical purposes. It's two in one. For example, in the second picture you can see it's a vacuum foam stent and this is the missing tooth filled with the acrylic, and you can make a tiny hole. Then you can whatever the material containing barium sulfate or even the gutta percha, you can fill it and insert it, and you can take the x-ray. Then you can get an idea about how what is your the angulations, and you can bit of ideas you can get it. Okay, this is the conventional way I'm talking about. Or you can design it and you can 3D print or any other sophisticated things you can use to make the templates. Okay, the diagnostic imaging are very, very important. Okay, you need at least IOPs and OPGs, at least. But remember, those two radiographs are screening radiographs or the diagnostic radiographs, but based on radiographs, never ever plan or never ever design your implant processes. Remember, if you want to really want to do a good quality work, at least you have to take a CBCT. Then only you have to have a proper idea about what's going inside the bone. That is 3D imaging. You can slice it in every except of every axis, then you can get a better idea. If you want to go for an implant, I mean, if you want to be an implantologist or if you want to go for a clinical implantology, you have to be very thorough about these things, because some of the things must. For example, reading CBCT and manipulating CBCT is very, very important and fundamental requirement if you want to place the implant. Okay, now the trends are going towards the digital era. Then if you have DICOM file, I mean, if you have CBCT or digital radiological images, it gives you the inside of the bone, then outside contour of the soft tissue, and every outside components are not recorded that much in that DICOM files. That's why you have to think about the digital scanning. Either you can go for intraoral scanners or extraoral scanners. Usually it's contain STL files. Okay, those are the two different software soft files. I want to go for a little details about the intraoral and the extraoral scanners. You know, usually the intraoral scanners you have to connect, you have to do in the patient's mouth by yourself, it either wire or wireless intraoral scanners. But believe me, extraoral scanners are more accurate than the intraoral scanners. Okay, what you have to do is, if you don't have intraoral scanners, you take a very good impression by using the impression material and send it to the lab. Those who have extraoral scanners, we call it as a dextaf scanners, then you can get a good image of extraoral image. Then you can combine them together. Here you have a accusation of the extraoral, and you have the DICOM as well as the STL file. Both you can combine them together. Then you can plan the prosthesis or the splint. Then you can send the information to the 3D printer. Then you can fabricate your implant surgical guide. By using, you can place the implant. That is the fundamental way to craft your smile in a better way. That is the trend, right? If you really want, if you all really want, I can do another series of lectures regarding the digital implantology. We will do, because that is the lag behind in Sri Lanka. We have to do that because that is the trend. Now you can't avoid it, because if you want to go and if you want to improve your quality of your work, definitely you have to think about it, right? Okay, then the most important thing is the implant processes design. There are a couple of guidelines. You have to think about the biochemical guidelines as well as the occlusal guidelines, and abutment selection guidelines are very important. And the prosthetic design is based on the biomechanical is emergence profile is very, very important. It means the contour of the gingival area, or the emergence of the gingiva, right? It's very important to maintain the aesthetic of the soft tissue architecture as well as a natural tooth. At the same times, it gives you the 3D placement of the implant, right? In here, you can see the emergence profile in this image of the first one. At the same time, in the first and second, A and B images, you can give the difference of the emergence profile between the ready-made abutment as well as the custom-made abutment. Okay, usually in whatever the implant system you are using, usually you can get the abutment. Those are ready-made abutment. But once you use, if you want to go for a real emergence profile, you have to think about the custom-made things. Here, usually you can get the emergence profile or your gingival form by using the healing abutment, right? Then sometimes you can't achieve that much of a good quality because this much of a tiny healing abutment, ready-made abutment give you a tiny bit of a gingival form. Then, for example, the first image, you can use the ready-made healing abutment and you can get this kind of a tiny gingival form. Can you see either side, mesial and distal to that gingival emergence profile? You can see there are a lot of soft tissues are still there. It means once you place the crown, definitely you have a black triangle either side because you can't get the contour, right? Look at the second, sorry, look at the second images, the difference between the first and the others, because here the first photographs you can see here, there is a custom made gingival former is placed. Once you remove after 2-3 weeks, you can see the nice gingival formation right around the implant. Imagine once your crown is emerged through this thing, it definitely end up with like a natural tooth. Okay, always recommended and encouraged to go for a custom made gingival formers if you want to craft a very beautiful smile. Okay, then look at this. Here, this is a junctional epithelium and the sulcal length and the mucosal margins are coincide with your fabrication of your implant restoration. Imagine if this crown is placed into this implant, you can achieve 98 to 99% of natural look. Okay. In here, compared to first one, second one is far better than the first one. Look at here, in between the two adjacent teeth, you have enough and more bone. I'm talking about this 2D one because it's already placed. I believe there are enough bone quality and quantities there. I'm just interpret the two implant. I believe those are very good and nicely also integrated and functionally well. But here, my worry is the first one. Look at the emergence profile, very narrow, and ultimately it's going to be very wider because that dentist somehow have to cover the mesodistal distance and he didn't plan properly and place the very narrow implant even though he has a lot of bone in between the two teeth, right? Compared to the first one, second one, he used the wider implant. Look at the emergence profile as well as the contact area. Here, very good and very nice contact area in the second one. The first one, you have a contact points. That is the issue because in between this contact point, huge void is there. Then it can be end up with food packing and gingival recession and bone resorption, and ultimately it can be lead towards the implant failure. Okay, Then the diameter of the implant, it's a very important, as I previously said, it's very important to go to gingival emergence profile, as well as it should be affect and extended laterally to the implant more than one implant diameter. It can be end up with cantilevering, right? I'll explain what it is. At the same times, you try to go for a narrower occlusal table using 2 implant, or if there is enough space, you can go for a wider diameter implant. These are the 2 compensatory mechanisms you can use to prevent the overload of particular implant. It means if you have a big space, you can try to manage for a 2 implant, or you can manage with a wider implant. Don't place a tiny implant as a sake of going for a good osseointegration, and ultimately you are making a wide crown on top of the tiny implant. It can be cause for different and varieties of unwanted things. Okay, especially the lower first molar site, you have to be carefully planned because it's a mesial distal distance, usually over 10 millimeter. It means nearly 1 centimeter width, right? Then imagine, this is a small question I'm going to give you. Distance about 12 millimeter. Okay, imagine what is your choice, right? What is the choice of your diameter of your implant? Here, if you have a 2 millimeter, okay, right? They said at least you have to go for a implant size 5 millimeter, because placement of a wider body or 5 millimeter diameter instead of 4 millimeters along with the narrowing occlusal plane is intended to compensate the overloading, right? In previously, they said implant single crown should not extend laterally to the implant more than 1 implant diameter. That is the principle, right? For example, if you go for a 4 millimeter, this side another 4 millimeter, this side another 4 millimeter. It means you are cantilevering 4 millimeter with the 4 millimeter implant. Okay, either side you have a 4 millimeter cantilever in distally and mesially. It can be affect your gingival emergence profile, as well as it can be overload your implant. Then instead of going for a flow implant, at least if you can go for a 5 millimeter implant, then this side you have a 3.5 millimeter and this side you have a 3.5 millimeter. That's how you have to tackle these cases. If you can go for a 5.5 or a 6 diameter implant, it's much better. Okay, then the gingival, the crown and an implant length ratio is very important, right? Because once you increase the height of the crown compared to the length of the implant, it can be vertically cantilevered. Okay, easily you can see in this diagram. Look at the forces here. Forces apply on the abutment and the fixture junction, right? Once you have a longer crown, there are more unnecessary forces apply on this butt joint. Then either it can be cause for implant crown loosening, or it can be fracture your crown, or it can be lose your entire implant. Therefore, you have to think about the implant to crown ratio. Then other guidelines is the extrinsic and premature contact, and the cuspides and the centric contacts are very, very important to implant protected occlusions. Okay, I'm talk this one at the end. We will discuss with details, right? Then the next thing is you have to think about the position of the implant. Okay, once again, the tissue aesthetic and the correct positioning of the implant is affect, right? Because if you don't place in a proper place, definitely your soft tissue contour and the aesthetic going to be affect. At the same time, if you place the implant in a mesiodistal area not in a centered position, again you are creating a bad emergence profile in one side as well as a cantilever to the one side. Okay, then it can be affect overloading of your implant and ultimately implant will fail. The fundamental rule is at least you have to keep 1.5 to 2 millimeter distance between the natural tooth to the implant surface. It means there should be at least 3 millimeter in between the two implant to maintain the viable bone and the good papilla. At the same times, there should be 2 to 4 millimeter below the adjacent gingival margin. I mean the implant platform or the head of the implant should be below 2 to 4 millimeter compared to your adjacent side gingival margin. And distally placed implant, once again, it gives you unnecessary forces of the implant and the abutment joint, and it can be affect for the bone loss and implant screw loosening and fracture. If you place implant in an awkward position, definitely your aesthetic going to be affected. Remember, with the implant, you can do a lot of wonders, right? But if you plan it a wrong way, it end up with blunders, right? Look at this. Okay. In this image, okay, that person is wearing ballet costumes, but you can, once you see that, you can see he's going to be a blunder, right? Okay, compared to the second dancer. Likewise, if you place your implant in a wrong direction, definitely your prosthetic going to be blunder, right? Okay, look at this. That case, you have a lot of buccolingual width here, but the implant is placed in buccally, and the angulation also not good and satisfied. Then what you have to do is, if you use uh, the abutment, then you have to cut it like this. Then the retention form going to be affected, right? And ultimately you end up with like this. Okay, then you can't make wonders with the implant if you didn't plan it properly. Okay, here this implant is placed far distally compared to the, because I believe this one is an immediate implant. That's why that unintentionally that implant is placed in the distal root socket. Okay, then what you have to do is some other how after osseointegration you have to compensate this gap. Sometimes you can't completely cover this gap because that much big. Then you are making a room to stagnate the food particles, as well as there is no contact point contact area with the proximal area. Then the implant loosening and unnecessary loading can be uh, applied on your implant. Look at the second one. If you place the implant far distally, you have to make a horizontal cantilever within the single crown. It's a badly effect on your implant. Here you can see the um, bone loss, and you can see the horizontal cantilever and bone loss, and here you can see the implant fracture also. Okay, that's why the implant positioning is very important, right? With this diagram you can get a better idea. If you want to place the implant, it should be 1.5 to 2 millimeter away from the natural teeth, and whatever the anatomical structures, vital structures, at least you have to keep 2 millimeter away from these structures. If you place the implant with close to one tooth, then you are in trouble to make the gingival contour and the emergence profile. Then you end up with this kind of a black triangle around the implant. Okay. This is things I told you. Usually you have to place the implant platform somewhere around 2 to 4 millimeter away from the gingival margin. Then only nicely you have to fix the abutment here, and nicely you can make the emergence profile. Then only you can get the aesthetically pleasing outcome. Okay. Imagine this implant placement is even without these interdental strips, you can't identify which one is the implant retain processes. That much near natural, right? Here, the implant position is perfect, gingival contouring, multi-shaded, and you can see the A3, A2, A1 kind of a multi-graded shading is used, and contouring, shape, golden ratio, and the pigmentation is blend with the gingiva, and everything is perfect once you place the implant in a correct position. At the same time, the diameter of the implant, angulations, everything is perfect, right? Okay. Angulation of the implant is very important because especially if you anterior teeth, if you are planning to go for a screw retain implant, your implant should be aligned with the cingula, right? If you want to go for a cement retain, your implant should be angulated through the incisal edge, right? If it is a posterior implant, usually it should be centered to your crown. Otherwise, it's going to be overloaded. This is the things I want to tell you. Here, if you want to go for a cement retain, it should be compatible with your incisal edge, right? It should be go through the incisal direction, right? If you want to go for a screw retain, it should be go through the cingulum area, right? Okay. Okay. What happen if you place your implant in a different angle? The bad thing is once you apply your occlusal forces, it definitely going to be an axial load once you placed in a correct position. But it's angulated in a different degrees. You can see how much buccal forces and axial components of forces applied in different angulation. It can be badly affect and ultimately end up with the bone resorption on the opposite side and can be affect for osseointegration. Then the angulations. Look at these angulations because mainly because of two reasons. One thing is this didn't plan properly. The other thing is didn't do any surgical guide or digital imaging. For example, at least if you use in CBCT, you can get a better observation and idea how to place and how to change the angulations before you do the osteotomy, right? Because I can't believe this kind of a placement, how they did, and ultimately they placed the crown also. But you have to be very, very vigilant and you have to be planned properly to minimize or stop this kind of a hazardous one to plan in your prosthesis after your osseointegrations happen, right? Okay, if unfortunately in this kind of a situations, right, for example, in such a situations, if you want to do some corrections, these are the options to correct the angulation. Sometimes purposely you have to place the implant in an angulated manner because of the availability of the bone. Sometimes you can avoid the bone grafting and second surgery, and at the same time there are enough bone there and you purposely place the implant little bit of a known angulations you are knowing without blind placement. You plan it properly, but then you can do this kind of a things. Number one, if you plan for a digital workflow and surgical guided implant placements, automatically you can minimize the wrong angulations of the implant. The other thing is you can, if unfortunately it's placed, then you can use the angulated abutment or multi-unit abutment, or you can use the screw retain restoration by using the UCAL abutments, or you can use angulated screws, right? All the previous things I think you can familiar, but angulated screws are like this. Once you keep it, the direction of the internal screw in a different way, but it's engaged in a different manner, right? Okay. Before that, before I move to the occlusion and the prosthetic things, if you want to do different mm, smile designs and corrections, you should know about the different types of abutment. Even this, I publish a book. Some of them know that. Then you can go through this book. If you want, you can get a better idea. If you no need to correction of your angulation, it's axially placed and it's a centered location, you can usually use the conventional straight abutment, and on top of that you can make the abutment. If you want to do some changes, known degrees, either 15, 10, 20, 25, like different types of and different varieties of angular abutments you can use to change the correction of the implant angulation. And conical abutment you can use uh, as a multi-unit abutment to go for a denture retention and even for the single crown in selected places. And custom-made abutment, this is a 3D printed ones by a CAD/CAM technique. Okay, and oval abutment usually we are using for the over dentures. And this is a temporary or interim abutment. You can either this one is made out of with the plastic top and the metal internal hexagon, as well as there are some kind of a serrated titanium uh, base temporary abutment. You can cut it and you can do some adjustments according to the opposing arch, and on top of that you can build the crown. I'll show you one case which I did, right? And this is the multi-unit abutment. You can change the angulation, especially if you want to go for a all of four or all on four or all on six implants and implant supported bridges. You can use this multi-unit abutment. And this is one piece abutment. There is no internal screw. You just matter of tightening into the implant. You can take the direct impression without using the impression coping or the impression transfer. This is the preferable abutment once you put it, and according to the patient's height and the opposite occlusion, with the high speed burr, with the copious irrigation, you can prepare this abutment and you can take the direct impression, right? Usually this is made out of with the titanium or some very soft material. This is the UCL abutment. It is a University of California, Los Angeles. That is the meaning of UCL. Okay. Here, these abutments are used to screw retain implant crowns. You can do the wax up around this one, and then you fabricate this plastic and wax will convert it into the metal or the zirconia or whatever the material. At the same time, this bottom metal part integrated with your crown. Then there is an internal hole here. Then you can put the internal screw and you can fix it into the patient. Right? Okay. Then next thing is once you place the implant, you have to think about the provisional restoration. Right? Sometimes provisional restorations, you have to think and decide whether actually this is needed or not. Right? Some instances actually no need. This is one of my cases. In this case, the implant is posteriorly, then no need to go for the interim or the temporary restoration for these cases. Or if there is any lack of initial vertical space, you no need to worry about that because patient is already used to this one. And this is I'll show you this case how did I manage. And this is the removable partial dentures, one option. Okay, remember, if you want to give a removable partial dentures, you have to always make a free occlusion and free of contact and premature loading of the implant. If you give for the implant, then always you have to keep a gap in between the implant and the fitting surface, right? You can use the clasp or extension of the base plate to get the retention, but don't load your implant during the osseointegration is happening. Okay, this is another case. In some instances, this is one of my case. You can use the temporary resin bonded bridges if patient is very keen about the aesthetic and patient is engaging in a social works, and this kind of a treatment options are available. This is the temporary crown you can give immediately after the implant placement. Immediate after, in the sense, couple of days later, you can do it, right? This is one of my cases. I used a temporary abutment, okay? Even after the preparation, the patient can't realize which tooth is placed, okay? Right, this is the tooth actually, okay? If you carefully look at here, you can see the gap in between the temporary crown and the natural tooth, because I never ever wanted to load this crown just to improve the aesthetic, right? Okay, here you can remove the healing abutment, then you can place the temp temporary abutment. Then you have to change the occlusion accordingly. Then on top of that temporary abutment, you can build up with the composite, take it out, and you have to smoothen it and remove the overhanging, and then you can fix it, right? Then we are moving towards the occlusion management. Okay, if you want to bear a lot of forces, right, then you have to think about the base and the forces apply on particularly on that implant is very crucial, right? Implant, as you know, there is no movement, but you know there are tiny bit of movements happen in a secondary movements, you know. But if the implant is overloaded, definitely it end up with the screw loosening, fracture, or bone loss, or the implant fracture can, or implant failure can be the end result. Okay, but in the natural tooth, you know, the periodontal thickening and mobility, wear facet and femmeters and pain, those are the indications and you can correct it. But if implant is loosening and you can see the mobility of the implant, end of the story, right? Then you have to always think about the occlusal management, right? Then number one, you have to think about the premature contact. If there is any premature contacts, it can be happen either deviation of the mandible, for example, the postural positioning, or if there is any interference of harmony of the occlusion because of the unnecessary gliding movements of the mandible. It may be because of the over eruption or over contoured crown if there is any thing already done in the patient's mouth. Those kind of unnecessary premature contacts you have to eliminate it before you plan the implant. Then the extrinsic and premature contacts are very, very important to identify at the beginning, because harmonized occlusion is very important in the natural teeth, as well as protected implant occlusion also very important to maintain the integrity and the sustainability of the implant. Okay. At the same time, if you are planning to replace the canine with implant, remember, don't keep any contact, right? It means you have to avoid the canine guidance. Otherwise, definitely your implant canine crown going to be fail, right? At the same time, you have to establish the group function. Okay, once the patient is doing lateral excursions, always try to avoid the canine guidance and go for a group function. As well as new occlusion, you have to do the over engineering, as well as you have to give the night guard if patient is having a bruxism. Over engineering means you have to recontour the crown height and the curvatures and the designs. For example, if you are planning to go for a cantilever of two teeth together, for example, canine and premolar, or two premolars together, you can make them as a canine shape. Then you don't have a functional cusp on those prostheses, then it's long last. Likewise, you have to think about. Okay, then the mid cuspal height is very important, because usually once you do the normal usual centric occlusions, you have to check with that occlusion by using 25 micron articulating paper. This is a normal tapping force, right? Once the patient is biting with the light tapping, then you can get the mark on the abutment teeth as well as the adjacent teeth of your implant. Then you have to do the trimming and contouring of the adjacent teeth. Okay, then you have to think about the centric contour. Also, contacts also very important, because after premature contact adjustments, usually there shouldn't be any contact in the anterior teeth, and there should be a greater initial contact surrounding the natural teeth, because usually that occlusal forces are distribute among the natural teeth. At the same time, you have to minimum initial contact should be in the posterior implants, right? Anterior, there shouldn't be any contact. Posteriorly, you can get a minimum contact, because it's always axial loads, because there is no such angulation, especially in the posterior teeth. But anteriorly, because of the contour and the shape of the bone, your implant anyway, it's angulated. Therefore, there shouldn't be any contact, right? How to check it is, usually you have to check that fully engaged, or once you have the musculature bite, or I mean, once you twin, you have to check that occlusion with the sim stocks, right? Okay, I'll show you how to do it. It's kind of a polythene, kind of a tiny cellophane material. And this is a video if you want to check it, right? Okay, that's how you have to check the light contact as well as the clenching contact. Usually once a patient is, I think you understand what's going on there. And next thing is, once you remove the premature contacts, there shouldn't be a heavy contact on the implant. And at the same time, in the posterior teeth, usually you have to have the centric occlusion like this, center of the fossa. And if you have a secondary contacts, should be within the 1 millimeter around that fossa. At the same times, the implant protected occlusions, once again, there should be minimize of unwanted, angulated, awkward force apply on the implant, right? If there is such a things, you have to think about then you have to avoid by the overload by using short cantilevering, always prefer. And you have to think about the long implant, and you have to do the ridge augmentation. If there is a narrow implant, narrow site, then you can get the nice bone contact right around the implant. In addition to that, you have to reduce the crown height, already we discussed. Then you can reduce the vertical cantilevering and increase the soft tissue support. It's very important for the aesthetic as well as the function. And if there is any parafunctional issues, it's advised to go for a night guard. Okay. Now we move to the multiple teeth replacement. Here, there's no need to talk that much of a things like uh, single tooth replacement, because if you know a lot of things regarding the replacement of single teeth, same principle you have to apply. There are some exceptionals. We will only talk about those things, right? Number of missing teeth and the pontics, angulation of the implant, parallelism, and the design of the restoration, and how to support or the retain the implant restorations and occlusion are the main things, right? Here, number of the implant is based on the force applied on it, right? Either you can go for a single implant for each and every a crown to replace, or you can think about the combination of a couple of implants to combine them with the Pontics, right? Then once again, you have to think about the additional implant placement based on the force distribution and the load. At the same time, in the anterior teeth, sometimes you have to think about the additional implant even you can manage with, because otherwise it can be, especially if there is a posterior teeth missing, it can be overloaded and it can be affect your smile one day if the implant prosthesis is failed, right? The the parallelism is very important. You can achieve this one easily with guided uh, surgical template, right? At the same time, if you have implant angulations, right, there are some method to correct it, and you can measure with the implant trying kit, and then you can measure the angulation, and you can use a different angulated abutments and combination with the angulated and straight abutment, then you can use it. Or you can think about the screw retain abutment, right? In this case, you can go for a closed tray impression, and here you can go for a open tray impression, right? How to parallelism means the implant is another thing. Here, even the implants are parallel each other, but their position is wrong. The second one is obviously they are uh, in a wrong position. Then you are in trouble once you go for a restoration. Okay. This is never going to do that. Usually don't fix the natural and implant together. Then you are in trouble, because if you're especially in the anterior region, if you connect implant and natural teeth, you are end up with trouble. Don't plan such a things, because you know there are some natural movements in the natural tooth, but there is no movement in the implant. Definitely implant going to be fail, right? In some instances, with the precautions, you can use the angulated abutment and cantilever designing like this with the angulated screw. In this case, you can see that, but you have to with the precautions like this. If you have occlusal forces and premature contacts, your smile going to be affected if it is not planned properly. This case also same. You can see in this case, there are a lot of posterior teeth are here, and long implant bridges are fixed on the anterior region only. Then it's overloaded and ultimately end up it like this, right? Always once you plan your smile, think about the mutually protected natural teeth occlusion as well as the implant protected occlusion combinedly. Okay. Then support can be either retention, or the support you can get through the screw retain or cement retain, or you, if you are talking about the dentures, you can get the implant and the mucosa bone support, right? Then always think about the group function for the improve the harmonized occlusion for the implant. It will long last for a longer time. Otherwise, it can be overloaded and end up with the trouble. Okay. Then we move to the edentulous arch management. There are different ways to manage the implant supported over denture for the edentulous cases. This is the classification. I am not going to go for a more details about this one. Usually there are fixed prostheses. There are three types of fixed prostheses, and here there are two types of removable prostheses you can use to manage the edentulous cases. Either you can use 6 to 8 implant for a mandible and a maxilla like this. Then you can go for a nicely, you can fabricate the smile with the 3D printing combination of your pink and white porcelain, and you can fix them together as a bridge. But remember, if you go for a lower full arch rehabilitation with the implant, fixed implant restoration, you have to split the um, bridge into separate units. Otherwise, it can be because of the shape, it can be affect for your bridge, and the expansion can be differ the natural bone and the ceramic and the metal. then it can be chance. There are some chances to fracture the mandible. Therefore, you have to separate the entire bridge into either 2 or 3 pieces. Okay, then these are the reasons to go for overdentures. One thing is if it is a morphological compromise or highly resorbed ridges, poor coordination and lower tolerance and anesthetic prosthetic experiences and gag reflexes with the normal conventional dentures, then you have to think about the overdentures. There are two types of overdentures. I mean, the removable prosthesis, you have to fix the patient's smile as well as the function. There are two different things. Either you can use completely implant supported bridges or the dentures you can use, or you can cantilever them along the splintered implant. According to the classification, there are two types: removable prosthesis type 4 and removable prosthesis type 5. Okay, here the don't miss up with the two implant. Usually we are placing for a two implant, that is combination of implant and soft tissue supported overdentures. Here we are talking about the completely supported by the implant. If so, you have to at least you have to place 5 implant for the mandible and 6 to 8 implant for the maxilla. Then denture is usually acrylic and you can fix it to the for the implant, right? Then the removable type 5, this is we are talking about the implant retain and tissue support combined overdentures. Here usually we have to place 2 implants. Now we are talking about the 1 implant retain overdentures as well. Okay, usually 3 implant, either you have to splint or you can use 4 implants and splint them together, or you can use a 2 implant independently, right? Okay, or you can use the mini implant also to go for a, right? Okay, usually the edentulous arches, you can divide it into the interforaminal area into 5 similar components: A, B, C, D, and E regions, right? Based on that, okay, either you can place 2 implants in B and D region, and then you can go for a overdenture you can construct, or you can place the implants similar way, same place, B and D place, and you can splint them together. Then you can use the attachment because there is a bar, then bar and clip attachment, then you can go for overdenture. Or you can use A, C, and E position implant placement, then splint them together, then you can go for a overdenture by using the clips. And here B, C, and D, splint them together and same. And overdenture 4 and 5 is the different because here they are using 4 implants and they are cantilevered the bar. Okay, the cantilevering is very important because here the advantages of cantilevering the bar is because you can use 2 implant or the 3 implants in between the interforaminal area, and you can splint them together and you can go for a full large implant. If you use 4 implants, you can cantilever about 1 centimeter from one side. And if you go for a 5 implants, you can cantilever more than that. Okay. Okay. This is based on the AP spread, we call it as, right? AP spread means the imaginary line in between the anterior most implant to the posterior most implant. If the distance is called anterior posterior spread, that's why we call AP spread, right? The cantilever part, you can extend 1.5 multiplied by AP spread, right? It means if you have a 10 millimeter AP spread, you can go for another 15 millimeter cantilever from each side, right? Okay. These are the types of overdentures. Always you have to think about the fundamental rules and the guidelines, right? You can use implant supported overdentures like this by using the metal housing or the other or ball attachment, or you can go for a fixed options like this. Here then you have to think about either the multi-unit abutment and screw retain complete fixed bridges, or you can place the implant and on top of that you can use a bar attachment like splint. Here this is the AP spread, here the AP spread. Okay, based on that you can cantilever the entire arch, and on top of that you can go for a over retain bridge. Okay, this is all on 4 implants. You can place 2 straight abutments somewhere close to the lateral region, and canine region you can use the 45-degree angulated abutment on either side by using a template, right? There is a surgical guide for that. You can place by using that template, or you can design according to the digital workflow, and you can drill through the rim, and then you have to fix the multi-unit abutment, and you can fix your prosthesis on top of that. Okay, or you can go for a subperiosteal implants because of the softwares and the digital improvements. Now this again came to the field, because previously it's a very messy situations, because you have to go for a two surgeries, because you have to open up the entire mucosa and you have to get the impression of the bone. Then you have to custom made the implant according to the bone. But with the digital and the software, now no need to do that. You have to take the DICOM and the HTML file, and you have to remove the by using the software. You have to remove the soft tissues by manipulation of the softwares, and you can 3D print, and you can convert that 3D print into a titanium implant, and ultimately you can go for a subperiosteal implant technique. Okay, this is a single implant. This is also, there are some couple of researches going on all over the world, and now they are accepting it, and there are a lot of good review and success with the single symphysial overdentures. And these are the cases. This is the last bit of latter part of my presentation. This is a one case, right? Here, this is a multidisciplinary case, and you can see there are a lot of implants supported single crown in this case. Very difficult to find even. But in this case, I want to tell you, patient doesn't like to go for orthodontic treatment. That's why I manage this case with a multiple implants like this in different places, right? Then you have to go for an articulator. And here the clinical tip is, okay, before you do the glazing of the crowns, you have to do the porcelain trial. What you have to do is you have to fix the abutments, and you have to insert the crown before glazing, and you have to do whatever the occlusal adjustment and all the contouring, cusp beveling, and everything you have to do, and you have to correct all the occlusal contacts, centric occlusion, lateral excursions, everything you have to check. Then you have to adjust it and then send it to the lab once again to do the glazing. That's how you have to achieve the results like this. Okay. Then here there is a different angulations. For that you can use the angulated abutment, and you can do that. And this is the smile is basically here the implant placement is difficult without doing orthodontic treatment. Then we open up the space and we can change the root configuration, I mean the root uh, tipping. Then you have to open up the gap in between the two crowns, and I was able to place 2 implants and ultimately place the crown in between the canine and lateral on either side. Okay, this is one of the cases. It's a combined case with the removable as well as the fixed prosthesis. This patient came like this, and two crowns, and there is a over retained canine, but canine is sound, but all the others are not in a good position. Then I discuss with the patient and educate the patient and went for a total clearance of lower arch, and ultimately I placed 2 implants by using a simple stent and do the total clearance of lower arch and go for a 2 implant for the over dentures. This is the end results. This is the full arch. Okay, here I placed 2 implants here, here, I mean 4 and 5 region, and I distally cantilever the 6 because my opposing arch is denture because it's soft tissue on, I mean it's a implant and soft tissue supported. There is no such a forced apply on this one. This is the pre-op, this is the post-op. Okay, this is the radiograph I wanted to show you. I cantilevered the first molar because it's opposing to the complete denture. Right, this is the case which I show you at the beginning. This is over erupted one, and I do the gingival contouring like this, initially like this, then I place the implant. At the beginning, patient did 2 endo already for the molar and the first second premolar. Then I did the elective endo for the first premolar because there is a carious tooth. Okay, then did the gingival recontouring as well as the crown lengthening and the bone contouring as well. Keep it for a couple of weeks to get the gingival recontouring. Then did the restoration for the lower implant retain and the upper conventional bridge. Okay, this patient with the heavy gingivally affected patient, and I did the total clearance of this one because all the teeth are class 3 mobility except the K2 for K9. They are also nearly grade 1 and grade 2 mobility. Then I did the complete clearance of this one and go for a 2 over retained implant supported over dentures. Right, these are the couple of materials you can refer if you want to get more idea about this one. If you want, I can send the entire articles if you want to read regarding the concept of implant placements and the technologies. Right, I think I can wind up the presentation now. Then if you have any questions, I like to give some ideas, and if you want to give any expression on the lecture, now it's time to do that. Kemia? Hello?
Thank you very much, Dr. Aruna. Yes, as the floor is open, you can please unmute yourselves and ask a question from Dr. Aruna regarding the lecture that was done today. Yes, Dr. Anuruddhi, yes, you can go ahead. Please.
Yeah, Dr. Aruna, thank you very much for your excellent presentation.
Thank you,
And
Anuruddhi.
Aruna,
Thank you so much.
it's nice to hear. Aruna, so I want to know if that anterior vertical bone loss is there in the maxilla, is it
Yes.
successful as horizontal bone block bone augmentation? So how we can do such a defect,
Yeah.
close
Yes.
such a defect? Yeah.
Yeah.
Dr. Aruna,
Yeah,
sorry
it's a
to
good
interrupt
question.
you.
Then
Is it possible for you to switch on your video?
yeah, sure. Yeah. Yeah, it's like this. Then there are different ways to do that, but usually if there is a horizontal bone loss, number one is you have to do the CBCT and you have to check whether there is a enough scaffold. I mean, there is any place to place the bone graft. Then usually you have to either you have to split the bone, then you have to do the bone splitting and expansion. This is the one technique you can do. It's completely depend on how much bone is available. Usually you need at least 6 millimeter. Then once you split on either side, you have a 3 millimeter. Then cortical bone and the soft bone is there. Then you can place the implant. Once you place the implant, if there is any gap in between the two split, it's more than 2 millimeter, you have to place the bone graft into that split. Otherwise, we call it as a jump healing, then definitely going to be heal itself. Otherwise, you have to damage the cortical bone with the burr hole, then you have to allow the bleeding, and on top of that you have to place the block bone graft, and defect you have to fill with the autogenous bone, and you have to put the membrane, and on top of that you have to put the full thickness flap we have to reposition, and you have to wait for about 6 months, then only you have to place the implant. In this situation, sometimes you have to use the titanium mesh to retain the bone graft, or you can use the stabilizing pin to hold the bone graft. Okay, these are the two options you have. Or if you have a minimum bone, but you can't go for a split, then you can use the denser burr. We call it as a densification burrs. Then you can expand the bone by using those burrs. Those are the three techniques we have to expand the bone if there is any horizontal bone defects. And vertical defects, if there is any vertical defects, either you have to go for a bone graft or you have to think about the recontouring of the soft tissue. It is very difficult because then it can be either over contoured or it can be increase the length of the white porcelain. Because of that, sometimes you can use the pink porcelain to overcome that gingival contour. These are the options we have to correct the bone and the soft tissue dehiscence.
Okay, thank you so much. Thank you.
Thank you. Thank you.
Okay.
Dr. Kumarogini had been unmuting her microphone. Dr. Kumarogini, you can go ahead. All right. Yeah. So, Dr. Aruna, you covered a wide range of aspects with regard to implant dentistry today. I think it was a wonderful lecture. I think you took time without missing any component, starting from the emergence profile up to the occlusion, and giving full mouth rehabilitation options as well. You did a wonderful job, so thank you very much for that. So what time is it in Brisbane now?
And now it's 3 o'clock in the morning.
Yes. Thank you very much for spending the night and
No,
until
that's all right. No
on
worries. No worries. I'm so happy to do this one because you asked me to do that, and I think I try to cover most of the things. It's a vast area, as you said, but I was able to do some of the things, but it's difficult. If you go for a specific areas, then we can go for a more details, but I didn't go for a very molecular level things because I try to cover most of the clinical stuff. I hope I did something. I mean, because it's difficult. But as I said, this is a very good exercise. You starting dentistry, and through that you are trying to do a lot of things. I'm so happy, and anytime please let me know if there is a within my capacity. Definitely I'll always contribute towards the profession. I really appreciate your effort, as well as I'm thanking to personally the KMEA as well as the government dental associations to invite me to do this lecture. Uh, yeah, all the best and good luck
Thank you very
for
much.
everybody.
And thank you for taking your time of your schedule, as well as
Pleasure.
you're still in the like training part. So I think it was
Yeah.
very difficult for you to find time for us. So thank you very much. So Dr. Aruna, I mean, at the moment, the cohort of dental surgeons who are with us under the dentistry program are, I think most of them are not practicing implant dentistry, and they are very new,
Yes.
but still they are still learning the concepts. So
Yeah.
on like the final note, what sort of advice would you like to give? I'm sure you shared some of your advice at the very beginning as well. Some sort of motivation as to become a
Yeah,
seasoned
because
implantologist.
yeah,
Yes.
it's like this, not like all the other day-to-day practice. Implant is one thing is cost effective, and you have to establish with the fundamental requirements and the facilities. But I mean, if you have attitudes and if you have a commitment to do something, definitely you can do it, right? Uh, because if you doing same thing over and over again and you are expecting wonders, never happen, right? If you want to expect a different thing, you have to do some different. Otherwise you can't expect different things. I mean, even it's a good or bad things towards the implant we are talking. If you want to do implant, you have to start it. Number one, you have to improve your knowledge within yourself. You have to improve the knowledge is nothing, because the internet and the sources and the resources are all freely available now. Then if you are keen to improve your knowledge, it's up to you, because it's completely, it's your control. Then there are lots more opportunities and avenues to improve your skills and practice. There are a lot of courses and lot of practical sessions are there. Even this forum, we can organize some of the hands-on training, and we can do something if the time permitted. Then you can start. At the same time, don't start very complicated cases, right? Or you can get advice, and under supervision of a good clinicians, you start one and first or two cases under supervision of your colleague or somebody who's doing implant very well. Then little by little you can improve. Definitely, because once we start implant, I think there are few dentists practicing implant. Now I think there is a trend. At the same time, don't stuck into the conventional thing. As always I am telling, now we are moving towards the digital era. You have to think about the digital dental implantology as well as the digital dentistry, because I also personally wanted to do something in digital lectures and digital workshops. Once I come, then we will do work together and we can do something. Yeah.
Yeah. So thank you very much, Dr. Aruna, once again for accepting our
Yeah,
invitation.
you're welcome.
Uh,
Yeah.
we have recorded the lecture and we'll be uploading it to our website, the Government Dental Surgeons Association website. So if you had missed the lecture, or if you want to go through the lecture once again to capture some of the like hidden points and difficult things that you found during the course of the lecture, I think you can go across and listen to the lecture recording. So thank you very much once again for being with us. And we hope that we'll be able to come up with a new lecture series in the upcoming year. So this would be the last lecture under the tenure of this sort of Board of Officials of Government Dental Surgeons Association. So we'll be meeting next month with the Dentistry Congress, where you will find some of the international renowned resource persons who will be coming to share their experience, and there are some hands-on workshops as well that have been organized. We will miss you, Dr. Aruna, in the Dentistry Congress, but I hope
Yeah, me too.
you will join
Me
us
too,
virtually.
yes. Yeah.
So thank you very much once again. So I'll conclude today's session. Good night.
Thank you. Good night.